But before we begin, I would like to respectfully acknowledge that the University of Alberta is located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. I apologize for the background noise, but I think for now I'll hand it over to Giovanni for that very reason. Thanks.
Thank you, Armin. And it is my pleasure to present this ground round, chronic thromboembolic pulmonary hypertension. It's a very, very innovative ground round with a surgeon and with a physician here from the Department of Medicine. So it's my pleasure to introduce Dr. Stephen Meyer. Dr. Meyer completed his medical school at the University of British Columbia, and that was followed by a surgical residency here at the University of Alberta. He had further training in clinical in cardiac surgical fellowship at the Mayo Clinic, followed by a transplant fellowship also at the University of Pennsylvania, and started practicing here in 2008. Is one of the columns of our transplant program, cardiac and lung, and now we're starting with this new Thromboendarterectomy program, which is very interesting. Dr. Weatherald, who will introduce the topic of the ground round, is also a pulmonologist, associate professor, joined the University of Alberta in 2002. He was a medical student here. He also had his internal medicine training at the University of Alberta, then was loaned to Calgary for a few years for the fellowship in pulmonary medicine. And just after that, he had a European Respiratory Society long-term fellowship in Paris with one of the fathers of pulmonary hypertension. And then he came back home and joined our team and is doing very well as well. So please.
Good morning, everyone. It's really a pleasure to be here with Dr. Meyer and to talk to you about chronic thromboembolic pulmonary hypertension. I'm going to start, first of all, with my disclosures here. None of these are really pertinent to the topic. My objectives are to go over what chronic thromboembolic pulmonary disease is, as well as pulmonary hypertension due to chronic thromboembolism, or what we call CTEPH, to go over some of the epidemiology and risk factors for these conditions, and then to go over some evidence-based strategies to detect these diseases, as well as what we know about prevention. Lastly, I'll review briefly the management of CTEPH, as well as the disease without pulmonary hypertension present, and then turn it over to Dr. Meyer to talk about pulmonary thromboendarterectomy and the outcomes from our program so far. So just to start off with some definitions, this has changed recently in the literature. So we talk about this entity called chronic thromboembolic pulmonary disease, which is defined as angiographic obstruction of the pulmonary vessels after at least 3 months of acceptable anticoagulation. This entity is broken down into what we've called CTEPH for a long time. This is when you have pulmonary hypertension, and pulmonary hypertension is a condition that's defined by a right heart catheterization measurement of the mean pulmonary artery pressure greater than 20. So it's not an echocardiographic diagnosis. It requires catheterization to establish. There's also this entity, we used to call it CTED, or chronic thromboembolic disease, but it's defined as angiographic obstruction, but with normal pulmonary pressures. And that is important because it has implications for what we do for treatment. So this is really not a disease of clot anymore. This is a disease of fibrotic remodeling of the pulmonary circulation that spans the entire precapillary side of the lungs. So we've got these large pulmonary arteries that come from the heart that are, we call them proximal vessels, down to about the lobar vessels. And then we have pulmonary segmental and subsegmental vessels. And then interestingly, there's also a strong component of a microvasculopathy in the lung. And this is really similar to another disease called pulmonary arterial hypertension, where you have thickening of the small vessels. And this really occurs in non-obstructed parts of the lung. So you may have areas of the lung with this chronic thromboembolic material, and you get this microvasculopathy in the non-obstructed parts of the lung due to probably redistribution of blood flow, mechanical forces, and shear stress. The pathophysiology of this disease after acute thromboembolism is not fully understood, but there are multiple mechanisms involved, including inflammation, impaired fibrinolysis, platelet dysfunction, von Willebrand factor, neutrophil extracellular traps, as well as inflammation related to T cells and macrophages. And as I mentioned, because even in the parts that aren't occluded, we see this other vascular disease result, all of which contribute to elevated pulmonary pressures. I like to say that CTEPH is an uncommon complication of a common problem. So people in the room, people in internal medicine, you will all see pulmonary embolism in your day-to-day practice. It's a very common condition affecting thousands, even tens of thousands of Albertans per year. And CTEPH occurs overall in about 2 to 3% of people who survive their acute PE. So it is uncommon, but the burden is actually quite large, and it's probably under-recognized. Among people who have acute pulmonary embolism, these are the risk factors for going on to develop CTEPH. And you can see they're not the same risk factors for developing clot in the first place. So it's really related to the burden of clot, the amount of the pulmonary circulation that's obstructed, as well as whether or not it's provoked or unprovoked, patients with recurrent PEs. And increasingly, we're seeing an association with chronic inflammatory conditions, including chronically infected intravascular devices or pacemakers, chronic inflammatory diseases like inflammatory bowel disease and other connective tissue diseases. Of the other hypercoagulable states, the only one that's really strongly associated with getting this condition after acute PE is antiphospholipid antibody syndrome, and they're particularly challenging to manage in the pre and perioperative setting. Interestingly as well, patients who are splenectomized, either surgically or patients with functional splenectomy, such as in sickle cell disease, these patients are at higher risk of getting CTEPH. So this is an older study, but this shows the natural history of patients with CTEPH before we had really effective interventions. And this shows the cumulative survival over 10 years for patients according to their mean pulmonary pressure at the time of catheterization at follow-up. So these are people who had their clots, they were treated probably with warfarin at this time. And you can see patients with normal pressures do quite well. But once you start to get pulmonary hypertension, the survival goes down. So patients with mean pressures in the 30 to 40 range have median survivals of only about 5 years. And when it's severe pulmonary hypertension, their survival is dismal, was dismal. Importantly, a lot of these patients actually present with CTEPH at the time of diagnosis. Conversely, a lot of patients present with pulmonary hypertension and are found to have CTEPH, but they've never had a history of venous thromboembolism. So it's important to consider both scenarios. When they show up with this at the time of their PE diagnosis, there are particular imaging features that can point towards CTEPH at that time. So I'll go around the clock here, starting here. So this shows an eccentric and calcified thromboembolic lesion in the main and right pulmonary artery right here. You can see central calcifications. Here again, this in the right lower lobe does not look like an acute clot. It doesn't have that bullseye appearance. This is what we call a web or a slit lesion with this linear blockage through the artery. We also have these areas of stenosis where there's sort of contraction of the artery due to fibrosis with a post-stenotic dilatation. Here you have also in the mediastinum dilated bronchial arteries that occur due to chronic obstruction of the lung. And so you get these collaterals and bronchial hypertrophy. You also see here a complete occlusion of the orifice of the left lower lobe pulmonary artery. And then frequently we see these old scars and that probably reflect resolving pulmonary infarct. So we'll see these peripheral lesions in the lung, as well as a very characteristic feature that's not specific to CTEPH, but highly suggestive on the lung windows here called mosaic attenuation. And this is due to that heterogeneous perfusion. So you've got areas of lung here that are hypoperfused and are darker in the periphery due to obstructed arteries with sort of central hyperperfusion, which is related to that redistribution of blood flow. You may also see features of pulmonary hypertension or the sequelae of pulmonary hypertension, most importantly, which is right ventricular dilation and right atrial dilatation. When you see right atrial dilatation, that's often a signal of chronicity. So that doesn't usually happen in the acute setting with a pulmonary embolism. And then similarly in the chronic patients with chronic pulmonary hypertension, the pulmonary artery will start to dilate. So all of these things, if present at the time of a diagnosis of acute PE, should make you start thinking that this patient may actually have CTEPH and requires close follow-up. So one question that comes up is, should we be systematically screening patients with acute PE for CTEPH? Well, the guidelines actually don't recommend that. There's no evidence that that's effective or cost effective. But what we should be doing is systematically following up patients with acute PE for symptom resolution. And we can use validated tools that can guide whether or not further investigations are warranted. This is a recently published paper that looked at several follow-up algorithms. This one's called the InShape-4 algorithm. And what they suggest is you look back at their index CT pulmonary angiogram from the time of their acute clot to look for those signs I just talked about. So signs of chronic clot at the incident PE, which include the things that I've spoken about. And if you have 3 or more of these, you should go on to do an echo at that time. If you have less than 3 of these signs at the time of acute PE, then you go on to this step 2, which is just to follow them up clinically and see whether or not their symptoms resolve. The indications for treatment really depend on the presence of symptoms. If they have symptoms, then you can look at the ECG criteria, signs of right heart strain on ECG, as well as an abnormal NT-proBNP. And if you have 1 or more of these criteria present, then you order an echo. If none of them are present, then you can consider CTEPH ruled out. Using this algorithm, when they validated, they found that in a cohort they did not miss, this was in a cohort of 171 patients, they did not miss any cases of CTEPH, 0% false negative rate, pretty good discrimination at 0.89 area under the curve, and only 24% of the patients actually even needed an echo. So it's probably a cost-effective screening algorithm or follow-up algorithm that does not overdo the echocardiogram. When you follow up patients with PE, a lot of them will still be symptomatic, and they're not all diagnosed with CTEPH. So we call this the post-pulmonary embolism syndrome. This is chronic symptoms despite treatment of PE. So new or progressive symptoms, typically dyspnea, exertional intolerance, or mental status impairment after at least 3 months of adequate anticoagulation, and it's not explained by pre-existing conditions. So some of these patients will actually have CTEPH. Some of them will have that chronic thromboembolic pulmonary disease, so angiographic chronic obstruction, but no pulmonary hypertension. Some of them will have right ventricular dysfunction without pulmonary hypertension, sort of a sequelae of their acute insult. And some of them will have what we call post-PE functional impairment, which is probably a peripheral muscle dysfunction and deconditioning syndrome, but they don't have CTEPH and they don't have pulmonary hypertension. And these patients may be amenable to things like cardiac or pulmonary rehab. So this is the diagnostic workup algorithm on the left of the symptomatic patient, and it sort of depends on how a patient presents to you. Sometimes they present with abnormal imaging, sometimes they present with unexplained dyspnea, or sometimes they present with an abnormal echocardiogram that suggests pulmonary hypertension. If you're seeing these people in practice, really the first step is to do a ventilation perfusion scan, okay? It's actually not another CT pulmonary angiogram. I'll get into this in the next slides. We also suggest doing an echocardiogram at that time to help also triage patients that need to be seen sooner. Some of them, again, don't have pulmonary hypertension. They may still have chronic thromboembolic pulmonary disease. And then, based on those tests, you can refer to a center such as the one that we have here at the Mazankowski Heart Institute. While waiting, we'll often order a confirmatory CT pulmonary angiogram, and in many cases, patients will go on to get a right heart catheterization as well as a conventional digital subtraction pulmonary angiogram, which you see here on the right. Again, this is just showing an example of a VQ scan. This is normal ventilation with some perfusion defects in areas of the lung that have preserved ventilation. Here's an echocardiogram showing a dilated right ventricle. Here's, again, a CT showing chronic clot, and this is what a pulmonary angiogram would look like, showing, very patchy and areas of complete loss of perfusion. In terms of VQ scans, this is the most sensitive test, so we recommend this first. It's the best at ruling out CTEPH. A normal VQ essentially excludes this, but it's not that specific. So there are false positives that are not due to clot. And then in a positive VQ scan, the next step is recommended to be CT pulmonary angiogram. This slide here shows the differential diagnosis. So we can sometimes see chronic arterial obstruction not due to clot, and this may be due to angiosarcomas, as well as metastases from other primary tumors, as well as rarely we see things due to vasculitis, things like Behçet's and Takayasu's can cause pulmonary arteritis, as well as some congenital pulmonary artery stenosis. And this case here on the right is actually from a case that Dr. Meyer operated on as well, a young patient with a pulmonary angiosarcoma who ended up going on to have this resected with a complete left pneumonectomy and is actually doing quite well several years out. And you can see here on a PET scan that there's actually increased FDG uptake in this so-called thrombus. So it's not a thrombus, actually. It's quite metabolically active, consistent with a tumor. In terms of preventing CTEPH, there aren't really any preventative therapies other than good anticoagulation. So using warfarin with an INR target of 2 to 3 or DOACs, really the key thing is to follow up patients for follow-up for symptom resolution. Interestingly, there's so far no evidence at all that systemic thrombolysis or catheter-based interventions for acute PE reduce the long-term risk of CTEPH. From the PATHOS study, this is intermediate risk PE patients who were thrombolyzed. There was really no significant difference in the incidence of CTEPH down the road. There aren't long-term follow-up studies yet from catheter-directed clinical trials. So in the last few minutes here, I'll just talk about treatment. And as I showed before, this is a spectrum of disease across the pulmonary circulation. And the treatment really depends on where these lesions are. And so the radiographic characterization is essential to dictate what patients get. If it's in the large vessels, they'll get pulmonary endarterectomy. If it's in the medium-sized vessels, they may get this intervention called balloon pulmonary angioplasty. And for patients who still have distal disease or residual disease after those interventions, they may be amenable to medical therapy with vasodilators to target that microvascular disease. And this Kaplan-Meier here just shows the survival with surgery as well as with BPA, which is quite a bit better than patients who aren't candidates for either of those interventions. Just briefly, the only Health Canada approved medication for this condition is called riociguat, which is a medication that stimulates soluble guanylate cyclase in the pulmonary arteries that leads to ultimately vasodilation, reduces the pressure, takes the load off the right ventricle, and improves exercise tolerance. This is the primary endpoint from the pivotal randomized trial here, just showing an improvement in 6-minute walking distance. Balloon pulmonary angioplasty is I would say emerged intervention that's still not that accessible here in Canada, but it involves catheter-based ballooning of these lesions in the lungs. And it's quite dramatic and effective when it works. So this shows a pre-intervention angiogram. This is the catheter in the left lower lobe. And you can see this very sluggish contrast with a bunch of narrow arteries. And this is after a few sessions of balloon pulmonary angioplasty. You can see markedly improved blood flow in the lung. Those vessels are bigger, and you can imagine that the pressure and the resistance to flow drops substantially after a successful intervention. This recent paper showed that among patients in an international prospective registry that really they could reduce the pulmonary vascular resistance, which is one of the key hemodynamic features of this disease, by 60 to 70% in over a third of patients, and less significant but still clinically meaningful improvements in a large majority, with really no risk of mortality and a relatively low risk of complications. And just then my last slide here is just to talk about that entity of chronic thromboembolic disease without pulmonary hypertension, which is a challenging condition. And we didn't really know whether this progresses to overt pulmonary hypertension over time, but this cohort from the UK shows that really they don't. In fact, these patients with no PH or even mild pulmonary hypertension have the same outcomes. They may undergo interventions if they're quite symptomatic and low risk, but their mortality was really not driven by their cardiopulmonary status. It was really driven by the presence of underlying malignancy as a risk factor. And in Japan, in some cases, they're doing angioplasty in these patients because they do have breathlessness related to the chronic obstruction. And this increases the dead space in the lung, makes it harder for them to breathe. And with BPA, they can reduce the pulmonary artery pressure during exercise substantially, as well as the what we call the VE-VCO2, which is just a measure of the efficiency of ventilation. And it's highly correlated with patients' dyspnea. So with BPA in low-risk patients, they can make patients feel better, even if they don't have pulmonary hypertension. And I'll finish there and hand it over to Dr. Meyer for the rest of the talk.
All right, perfect. Thanks, Jason. This is actually really fun to be working together with, it's a combination of medicine and surgery. We've really modeled this program after our very successful lung transplant program. It's very similar. It's actually a lot of the same people too. And we structured very similarly, and as a consequence, it's running very smoothly. For the next 20 minutes, I'll talk a little bit more about the surgical side of the disease. This is my title here. There's 29 syllables in there. That's a lot to say. So what we're going to do is we're going to, how do I advance the slide? There we go. We're going to shorten that. So we're going to take that from 29 syllables down to about 4 syllables here. So PTE for CTEPH. And this is what I'm going to talk about for the rest of our time. And I put this picture up here, and this is actually, there's 2 surgeons involved with this program. There's myself and there's Dr. Jai Nagendran, who's sitting here today. And then we have all our surgical residents here today. This is normally our academic half day on Friday mornings. And this is a picture I've waited about 15 years to take, all right? So this was our very first specimen. This was actually done last year, October 30th, our first case. And I'll go through the details of this specimen in a little bit, but it, it just shows you the importance of persistence and working hard, and eventually you will get, if there's something you really want to grow and develop, you get it. And again, it took me nearly 15 years before I finally got to take this picture. And it's something I'm very excited about. I have no relevant financial disclosures. So what are my objectives for the next 20 minutes or so? Well, it's to talk about the surgical management of CTEPH. I'm not going to go into the infinite details, but I'm going to let you give you an overview of what we do and how we do it, so you kind of understand the significance of what is actually a pretty big operation. I'm going to review the outcomes both at the international, the national, and the local level. And interesting enough, interesting way to end a talk, but we're going to talk about epidemiology again, because really that's absolutely critical for where we're at in our program development. Let's start with some definitions. So what are we talking about? So just to make it really clear, what are we talking about here? We're not actually talking about we're not talking about pulmonary embolectomy for acute pulmonary embolus. This is a specimen I took out of a patient a couple of years ago with a massive acute pulmonary embolus that was not amenable to thrombolytics. We're actually talking about endarterectomizing. We're actually talking about taking the lining out of the blood vessel, and Dr. Weatherald showed some really nice pictures of those very scarred vessels for what is a chronic disease, not an acute disease that came in this morning or yesterday, but for chronic disease that's evolved over months and usually years. The other thing I want to just clarify, you're going to see these are synonymous terms. In the surgical literature, you'll see them more using the term pulmonary thromboendarterectomy. I notice in the medical literature, Journal of Respirology, for instance, and stuff like that, you tend to see the term pulmonary endarterectomy. They're the exact same thing. They're synonyms. Something about the word PEE always gives me a little bit of chest pain, because whenever I hear that, I'm thinking about a cardiac arrest and a code blue. But one way or the other. But for the rest of my talk, I'm going to use the term PTE. I think Dr. Weatherald's given a very nice summary of the diagnosis and the treatment algorithm. You've got a patient that's been diagnosed with this. You've referred them to an expert CTEPH team, and I'd like to say that I think we're getting close to being an expert CTEPH team here. Lots of opportunity for evolution and growth and learning, but still I think we're getting pretty close to that. We've definitely got some experts involved. And as Jason outlined, there's some patients that are they're non-operable, either due to their anatomy, the actual disease in their lungs, or due to their comorbidities, or both. For instance, Dr. Weatherald saw a beautiful case in clinic yesterday, absolutely perfect anatomy, but she's 85 years of age, right? So based on her age alone, she would not be a candidate. And there are other candidates for Riociguat or balloon pulmonary angioplasty. Instead, what I want to focus on for the next 15, 20 minutes is the operable candidates. So the ones that we find are operable, and there's two main criteria: their anatomy and their comorbid health conditions. So let's talk about, in reverse order there, let's go through the comorbid health conditions. What is the ideal patient? Now there's a spectrum here. This is a bit of a sliding scale. Nothing here is absolute. But what is the ideal patient? Green, let's go for surgery. So it's a patient with a history of a prior DVT. If they've got a history of DVT, you can be pretty confident that whatever you're looking at on the imaging is probably CTEPH. We try to stay away from patients that have got signs of right heart failure. By the time they get to that point, their disease is quite advanced, and the benefits of surgery may not be as pronounced. Hopefully they've got no comorbidities, but that's a pretty rare event in the current era. They got clear disease on this concordant on images. So their VQ scan, their CT scan, and now we're using a lot of MRI, or actually MR angiograms, and I'll show you some. They're absolutely amazing. Bilateral lower lobe disease, that's where the bulk of the disease is. And hopefully they have a PVR less than 1,000 dynes. And once you start getting over that, you're not going to get as much reversibility. And something this is somewhat subjective, but the number of disease and lesions, their PVR is proportional to their disease. Someone's got a super high PVR, but only 2 or 3 lesions. They probably have some other form of pulmonary hypertension going on, and vice versa. On the other hand, there's patients where you take a yellow, you kind of a little bit of caution, you yield. We still operate on some, and I've got examples of our 3 cases so far, both of these. No history of DVT. Signs of right heart failure. Are they going to get as good a response? Significant concomitant left lung disease or left heart disease. You're looking at other classes of pulmonary hypertension. Patients that are NYHA class 4. Those ones may be a little too far gone. You may not get as much benefit from surgery, so it's always weighing risk and benefit. inconsistency on the imaging, and very elevated PVR. Sometimes once they get to that point, there has been so much remodeling of those other non-diseased vessels. As Dr. Weatherald clearly pointed out, that what you see is you obstruct a vessel, it's the other vessels that remodel and cause a lot of the pulmonary hypertension. You may be a little too far gone. So you look at that. The other thing that we look at is the anatomy, and this is the sort of classic classification of CTAF here, and we describe it as level 1, level 2, level 3, level 4 disease. This is a publication in JACC from 2018. It's a lot of the work from San Diego. San Diego is really the premier center in the world, the highest volume. When we were down there visiting them just last fall, they just done case number 5,000. 5,000 of these pulmonary thromboendarterectomies. So level 1 disease, the main PA, so a huge burden of disease, very proximal. There's level 2 disease, which is more starting in the lobar vessels. Still, you can reach it and still a high burden of disease. Level 3 would be described as segmental disease, smaller vessels. And then there's the subsegmental vessels, which we describe as level 4 disease. So as we're going through these cases, and we meet once a month, we go through the imaging, we go through the new referrals, the patients, and discuss these cases. And we go through this very carefully on all the imaging studies that we use. And we look at them. So level 1, that's that's an easy one. So level 1 disease, that's like the dream case. You know, huge burden of disease, it's proximal, it's easy to get to, you're going to take out a ton of disease, you hopefully will get a very good result. Level 2 disease, starting in the lobar vessels there, just a little bit beyond the main PAs, is actually very easy to get to, and you get a very good result. Level 3, you got to take it case by case, and as sort of a neophyte program, we're not going after this kind of disease yet. But this is definitely something within the range of surgery if they've got a lot of other potential factors where you think they're going to benefit. And level 4 disease, that subsegmental vessels, obviously there's a picture of someone having done this. This is a very old picture. Most centers would not go after this now. Now that we have riociguat and balloon pulmonary angioplasty, I don't think there's any center, any of the major centers in the world would go after level 4 disease because they've got alternative therapies. That's very distal, very hard to get to, unlikely to get much of a response. So anyways, we've reviewed the patient, we've reviewed their imaging, we've looked at their pathology, and we've decided that we're going to go on with pulmonary endarterectomy or pulmonary thromboendarterectomy. And this is how it's done. This is heart surgery. This is a midline sternotomy. It's done under circulatory arrest with we cool the head, and I'll go through that in a little more details. This is a paper I actually published with Dr. McGregor when I was at the Mayo Clinic in 2006. So again, a message to trainees here, medical and surgical, you'll do fellowships. You may come out of fellowship feeling hot and ready to do all the things you learned. You may not get a chance to do it right away, but you persist. It was almost 19 years later. And I had a lot of other things on the go in our program too, doing a lot of the great stuff. But it took almost 19 years before I finally got to do my first case. But we persisted, we built the program. It took about 5 years to really get the program off the ground when we really put our minds to it, but you persist. And 19 years after I wrote this paper, I finally got to do this. And so that's why that's so exciting for us. Persistence, right? It doesn't all happen at once. This is sort of a schematic, and I'm not going to go through the infinite surgical details today, but this is a schematic of it. You've got the patient on bypass. You open up, this is the right pulmonary artery between the aorta and the SVC here, you open up. What's key to this really is and this is what makes this surgery so difficult. And this is it's one of the few operations, actually the only operation I do with another staff surgeon, I do with Dr. Ajay Nagender, because it is so important that you get into this right layer. What you're doing is peeling off the fibrotic scar and that single layer of cells, the endothelium. Right here is the media, and here's the adventitia, and it's literally you have one cell layer to get it right or get it wrong. If you're one cell layer not deep enough, you're going to leave residual disease. If you're one cell layer, 2 cell layers too deep, you're going to injure the vessel wall and probably have major hemorrhage. So Dr. Nagender and Ajay and I do these all together as we sort of teach each other, keep an eye on each other, guide each other, because it is definitely challenging. This is, and again, you have to get this absolutely perfect layer. You have to have an absolutely bloodless field. You cannot have collateral blood in your field. So this is one of the few cases in cardiac surgery that we still drew with true hypothermic circulatory arrest. We cool the patient down to 18 degrees. We do a bunch of brain protective maneuvers. and we turn the pump right off, drain all the blood out. We used to do that for dissections and aortic heart surgery. We don't do that anymore. We found other ways to get around that. But in this procedure, this is probably one of the few procedures in cardiac surgery, we still cool them right down to 18, turn the pump off for 20 minutes at a time, and then get into this beautiful white plane without a single red cell in our field causing obstruction of our view. This is a slightly different perspective of it. Again, this would be, normally when we do these, Dr. Nagendran stands on the patient's left-hand side. I stand on the right. I do the left pulmonary endarterectomy. He does the right pulmonary endarterectomy. So imagine Dr. Giant standing there. This is your aorta. The head's up here. The feet are down here. This is the patient's right side. SVC is here, retracted out of the way. Pumps turned right off, perfectly dry field. And we've opened up the right pulmonary artery here, the right main pulmonary artery here. Here's the right upper lobe vessels. The right middle branch is probably right about there, etc. And you start just sort of peeling this layer. You just take your time and get into this perfect layer. You start peeling it away, and this is the endarterectomy concept. You're literally peeling the lining out of the vessel. And as you keep going, this is what you start to see as it evolves. And what's really important to realize here is you see those specimens, you're like, those little twigs, how are those making a difference when you take those out? Well, what you see here is that scarring here. And as soon as you release the scar tissue from the vessel wall just pops open, and you can see how it opens up these blood vessels again. And it's actually very tactile. You can actually feel it on the tips of your instruments as the vessel wall pops. It's an amazing feeling as that vessel wall just pops open. And you start to see how, even though you can see how scarred down it was, you push the vessel wall away, you're pulling out this specimen, and you get this big, beautiful open vessel here. We haven't gone on this specimen here. They haven't gone in here. There's one of those web slit-like lesions that Dr. Weatherald showed, demonstrated on those CT scan images there. So that's the procedure. And again, here's what you get. This one was a level 1 disease. This was our very first case. There's your right upper lobe, right middle lobe, right lower lobes down here. And similarly over here, this was the left upper lobes, the lingula, and the lower lobes here. And again, these look like, when you first take these out, you're like, that can't make a difference. But it's amazing. These vessels pop open, and it's amazing the change in their pulmonary vascular resistance, as I'll highlight in a minute. So let's talk about outcomes. All right. So let's talk about international outcomes. This is the University of San Diego. They are the sort of the premier institution. They were the first ones to do this. They've got the highest volume. And there's some important names on here. Dr. Victor Pretorius was our resident. He was a resident here 15 years ago. Went down there, did a fellowship. They liked him so much they kept him, and he's been down there ever since. And it was great to go down. We went down, spent 2 weeks with Victor and Dr. Madani watching these cases. We saw about 12 cases. There was one day where they were doing 2 cases in 2 rooms. It's amazing. We get to do one every 2 months. They do 2 in 1 day. And then there's Dr. Nick Kim. Dr. Nick Kim's a pulmonologist, their interventional pulmonologist. And it's just interesting, when we were down there visiting, he goes, oh, I've been to Edmonton. Dr. Modry had me come up and visit in the middle of winter. There was cars in the ditch. The roads were all icy. I don't think he's ever come back to Edmonton since then. So if you have a visiting professor, bring them in the summer. Don't bring them in the winter. They'll always remember it. I present this data. This data is a little old, but I present it for 2 reasons. I think this program now, San Diego's doing the craziest cases, right? So it's hard for us to compare us to what they're doing now. They are doing the 82 and 85-year-olds and the super high risk candidates. We're not at that stage. But back in sort of 2006, 2010, they are doing the cases that we are doing. So I think this is a very good benchmark for us. Plus, they very nicely summarized the data. And this was the typical patients they're doing back then. And this is kind of the patients we're doing now that we consider to be moderate risk, not super high risk. That's not something you want to do when you're starting out a program. Average age is 51. Most of our open heart patients coming for valves and coronaries are in their 70s, sometimes in their 80s. These are typically younger, healthier patients. Their pulmonary artery systolic pressures are typically 75, mean PA pressures 45. So, and Dr. Weatherald clearly went through all the definitions of pulmonary hypertension. So they have a very high high PA pressures and very high pulmonary vascular resistance to begin with. 719 was the average PVR in these patients in this cohort here. These are typically elective cases. These are not your crash and burn pulmonary embolectomies in that you just had a CT scan. They're hypotensive and hypoxemic, off to the OR for a pulmonary embolectomy, or most of the times now there's other options to deal with that. These are sort of usually pretty stable, sort of semi-elective patients. Very few are in ICU, only 2% were in pre-op. Pre-op were in ICU, very few were on inotropes or mechanical ventilation pre-op. But what's very key here is as I pointed out when I said patient selection, we don't tend to operate on the NYHA4 patients, and that's kind of reflected in this series as well. Most of the patients were either NYHA2 or NYHA3. 90% of the patients were NYHA2 and 3. And this is their post-op outcomes, so or perioperative outcomes. So PVR pre-op was 719 when it was measured post-operatively. Usually they measure it in the ICU. And when they get to the ICU or in the OR before they leave, PVR went from 719 down to 253. So dropped the PVR by almost 2/3. Doesn't completely normalize right away. Remember, there's still a lot of residual disease that in those non-diseased vessels, there's the chronic remodeling that will continue to improve with time. Systolic pressures went from 76 down to 42. These are long cases. These are all-day cases. The average bypass cabbage case or a valve case says 3 or 4 hours. These were 9-hour cases. These are all-day cases. So John and I get to spend the whole day together. Pump times, this is more surgical, 264 minutes. Normally it'd be 100 for most other cases. So they're long cases. But what's impressive here is their perioperative mortality was 2.2%. So that's quite a benchmark for us to achieve here. So we're going to work real hard to get that benchmark. A lot of that is about patient selection and excellent perioperative care. Dr. Weatherald showed you those survival curves there. As about a 50% mortality at 3 to 4 years with no treatment alone, especially if they have significant pulmonary hypertension. That's what you see here. Here at 3 years, this is non-treated patients that were not treated for a number of reasons, often due to comorbid health conditions. But you can see 30% mortality at 3 years without intervention, 10% mortality with intervention. So that's a 20% absolute difference in survival just at 3 years alone. And that's statistically significant. So the intermediate outcomes at 3 years, pretty good. And then when you follow them out to 14 years, you have about a 70% survival at 14 years. So that's almost a natural survival curve for most patients. Is Dave Ross, one of our old surgeons and one of my probably one of my mentors and probably one of my favorite surgeons, used to say, we don't just do surgery to make people live longer though. We do it to make them feel better, right? Quantity and quality of life. So here's a study from David Jenkins, Papworth at Cambridge there, and Jason put up a lot of papers from Cambridge. They're kind of the major European center for this, or at least the major center in England. You can see here, 6-minute walk test went from 269 pre-op to 367 post-op. NYHA pre-op, only about 8 to 9% of patients were NYHA class 1 preoperatively. So the remainder were class 3 and 4. Post-operatively, 83% of patients are NYHA class 1 or 2. So no symptoms at all or very minimal symptoms. So a huge difference. And it's not surprising. You've significantly dropped their pulmonary vascular resistance. You've significantly improved their cardiac index and cardiac output. That's international. Here's some Canadian data. One of the major center in Canada right now is Toronto with Marc-Guy Perreault and their team out there. This is their data from about 10 years ago now. I haven't seen any more recent data. Their volumes have gone up substantially. So, but very similar data. Long cases, again, about 40 minutes of circulatory arrest, usually broken up into 20-minute intervals. They're ventilated for 2 days. They're in the ICU for 3 days. A lot of my open hearts, valves and cabbages spend more than 3 days in the ICU because they're so sick. So this is pretty impressive for such a major operation. Hospital length of stay, 13 days. And like San Diego, that had a 2.2% mortality. This group had a 3% mortality. So again, that's kind of the benchmark that we're aiming to achieve. And then what's the local experience? Well, I don't have a huge series yet to put in a tabular form, but what I'm going to do is spend the next couple of minutes just going through the 3 cases that we've done so far that I think highlight a lot of the stuff that Dr. Weatherald and I have talked about so far. The first patient was a 54-year-old male. Interesting enough, no history of pulmonary emboli, but he was noticing increasing shortness of breath. Plays men's league hockey. Was just finding he was getting more and more winded. He had an echocardiogram that demonstrated some pulmonary hypertension with an RVSP of 54. Wondering where that's coming from. He was sent for a VQ scan, which showed multiple mismatches consistent with CTEPH. So just like the diagnostic algorithm that Jason had put up earlier, this went through the perfect diagnostic algorithm. Then he went on for a CT scan, which confirmed the diagnosis. And this was the disease, some of the disease here. So this was our first case. We were using CT scan back then. I'll show you some of our subsequent imaging, which has gotten really quite amazing. And he had a pulmonary angiogram. So we still very much rely on our good old fashioned pulmonary angiogram. You kind of get that one shot. You cannot do this with any other imaging study where you see all the vessels all at once. So this is just his right lung. His left lung had a lot of disease too, but you can see stenosis, maybe it's a little hard to appreciate stenosis, and then sort of these very small vessels down here. And then there's this kind of mosaic pattern where you see, decent perfusion in this lobe here, but lack of perfusion to the right upper lobe and the lower portions of the right lower lobe as well. So that mosaic pattern, a lot of the features that Dr. Weatherald had shown in that his image, those CT scan images. He went for a right heart catheterization. PA pressure was 54, mean 54. His pulmonary vascular resistance was 350 dynes. So significant pulmonary hypertension, and we just went ahead and did a pulmonary thromboendarterectomy. You saw that massive lesion on the CT scan there, and that's what we took out of his right lung. That was Giant that took that out. In the OR, we've developed a very structured routine for measuring pressures. We put in a Swan-Ganz catheter, a PA catheter at the beginning of the case before we started. PA pressure, he had a systolic of 69, mean of 49. PVR was up to 752. Cardiac output was 3.95. This was the measurements after we completed the case. When he got admitted to ICU, PA pressure was down to 38, so almost half pre-op, half pre-op. His cardiac output had almost doubled, and his PVR was down to 1/3 his pre-op values. He went home on post-op day 14. We moved pretty slow with him on our first case, so we didn't rush him out of hospital. He was seen 6 months later in clinic. He's now NYHA1. He was a good solid 3 before, 6-minute walk test. 495 meters, and hopefully we'll be back out playing men's league hockey. So that's him. That's our first case, and there's our CT scan. Pulmonary arteries look nice and clear. It's kind of hard to show much in a single slice. This is case number 2. This was one we did this spring. This is a 54-year-old female, long-standing history of documented pulmonary emboli. She was experiencing significant right heart failure symptoms. So remember, we said that's not really the ideal candidate, but everything you kind of got to weigh, everything's kind of risk and benefit. She had a transesophageal echo that showed her PA pressures were again in the 50s. She had moderately severe TR. She went on to have her VQ scan, kind of the common theme, common pattern here, and multiple perfusion deficits. CT scan and MRI, bilateral chronic thromboembolic disease. So we've gone from CT scan, which we still do, to Dr. Coulden, who's our radiologist, who's worked at Papworth for many years. So it's just amazing having someone with all his experience. He saw many cases of CTEPH over the years at Papworth in England there. And so he's been moving to MR angiogram. So this was a 2-dimensional MR angiogram slice. And again, you can see significant disease, right upper lobe, middle lobe. It's hard to capture it all on here. Left upper lobe here, complete obliteration of the vessels to some of the right lower lobe. So we took her to the OR, and this is the specimen we got out of her. So right and left-sided specimens. Her PA pressures at the beginning of the case were 83 down to 46. Mean PA went from 55 down to 29, so almost a 50% reduction. Cardiac output was 5.28 inch. Enough, it was still a little low at the end of the case. And that could be just some of the stunning, just some myocardial dysfunction initially. But her PVR, again, 700 down to 360, almost a 50% reduction in PVR. She had a little bit of bleeding from her left upper lobe. This is a pretty common thing. This happens in about 5 to 10% of cases. We were lucky enough to see when we were in San Diego. They've got a very well-described nomogram. We've got a dedicated anesthesiologist for this case. He knew exactly what to do. Put the endobronchial blocker down. She did fine. So she was recently seen in clinic. Remember, she had right heart failure to begin with. She's still struggling with an ankle edema and limited mobility. She's also quite large. She's a BMI, I think, around 44. So she's got some osteoarthritis and other issues in her knees. She's not the most mobile person to begin with. But she's otherwise doing well and feeling much better. And here's case number 3. 65-year-old female had developed a PE while attending a wedding, just becoming more symptomatic. This lady was incredibly symptomatic. She was almost NYHA 4. She could barely even walk across her apartment without becoming short of breath. She had significant level 2 disease, so lobar and segmental vessels. Her PA pressures were 44 pre-op. Cardiac index was 2.3. But this is where we've evolved. So Dr. Colton now is doing these 3D MR angiograms. They're absolutely amazing. I didn't put a video in here to spin it, but you can spin this around like any other 3D imaging now, and you can look at the pulmonary vessels from left and right and top and bottom and rotate around backwards. And it's so critical for Gina and I as we plan these operations. The imaging is absolutely amazing. So again, having a great team of very keen people is so key. But she's got lesions here. You can see some mosaic here, lots of lesions. And you can actually see all the 4 main segmental arteries to the left lower lobe had significant disease. This is the specimen we got out of her. So very impressive. There's all those left lower lobe vessels. Her cardiac output at the beginning of the case was 2.78. That was an index of, I calculated, it was 1.9. I didn't put it in here, but it's in cardiac index of 1.9. Remember, cardiogenic shock is an index less than 2.2. So at the beginning of the case, by definition, she was in cardiogenic shock. At the end of the case, she still hadn't completely recovered. And again, that's just sometimes some stunning from the long operation, the long cardiopulmonary bypass run, but her PVR was 50, it was down to less than half of pre-op. Post-op day 9, she went home. She was actually just seen in clinic. I should have updated this, but she was just seen in clinic a couple of weeks ago. She's feeling well. She's kind of in the NYHA 1/2 range still. She hasn't fully recovered, but her symptoms are much better. She's gone from can't even walk across her apartment to go to the bathroom to now having sort of NYHA, sort of encroaching on NYHA 2 class symptoms. So a significant improvement, not totally normalized, but close. So those are our 3 cases. I told you it's taken a long time to put this together, and it has, but we've put together an amazing group of people. Dr. Ria Verghese, who's on maternity leave right now. I don't know if she's actually on the Zoom call or not today, but she's off for a while. She's our medical lead, along with Dr. Jason Weatherald and Dr. Dale Lean. I've taken the lead, the surgical lead role, and I do this together with Dr. Jaya Nagendran, who's sitting here with us today. Dr. Colden, who's just is amazing. He's been doing this for decades, and just listening to his experience when he reviews these images. And we've got Dr. Raul Pereira and Finn Usel as well, who are, because I got a funny feeling Dr. Colden's probably going to retire in the next couple of years. So we've got a really great group of radiologists here, and they're all doing a phenomenal job helping us out. Dr. Anoop Matthew from Interventional Cardiology. We got to get a right heart cath for these patients. So between Anoop and our interventional radiology, we were able to get him in for the right heart caths. We've got Dr. Rohan Parab here and Dr. Reddy, who are our interventional radiologists who are shooting these beautiful right-sided or doing our right-sided PA caths as well, but giving us those beautiful pulmonary angiograms. And we're working hard to get these guys down to San Diego for a few weeks of training. It's probably going to take a couple of weeks down there at least to get experience with balloon pulmonary angioplasty. That's the next step for us. We've got a dedicated intensivist. All the intensivists will look after these patients, but Roman here has taken the lead on that. We've got our lead anesthesiologist here, Dr. Berube. And again, that's so key. So when we had that bronchial bleeding at the end of the case, Joelle just knew what to do and just dealt with it. While Gina and I are doing our stuff on our side of the drape, Joelle was all over it. It was so efficient, so amazing. There's nuances to the heart-lung machine, the way we run it for this case. So we've got 2 dedicated perfusionists, and I've got a couple of nurses. There's a few other nurses that are very involved with the case, but have really taken the lead, organizing the cases, getting the instruments. We had to buy up $40,000 worth of instruments for this, some of which was funded by the University Hospital Foundation. So thank you to them for that. And Kimberly Lindroth, who's the nurse practitioner who's really helped keep this program together. She coordinates everything. And that's why I'm so, it's fun to do these cases. Great to work with this great group of people. But what's really exciting about this as well is you look at the map here. These are the centers doing these cases in Canada. Quebec does, I think, about 10 to 12 is my sort of sense. Ottawa's doing a few, but slowly winding down as the surgeon there approaches retirement. Toronto really does the majority of the cases in Canada right now. And until a year ago, patients would have to fly from Edmonton to Toronto. They still fly from Calgary to Toronto. They fly from Vancouver to Toronto to get these cases done. So AHS will pay for their procedure. It won't pay, I think it pays for their flight. Family have to go with them. AHS will not pay for the family. So this is a very expensive endeavor for many people. And I don't know if many people here have ever had to book a hotel or an Airbnb in Toronto. It's not cheap. So this is a huge expense and inconvenience for many families. So we're really excited that we can offer this to patients in Alberta. And I'm going to end with epidemiology, because I think this is actually really a big part of why we're here today. Jason and I, is to talk about this. You know, as Jason said, about 3% of all patients that develop a PE will develop CTEPH. Doing the math, that means we should be seeing at least 150 cases of CTEPH per year in Alberta. But this is actually what we see. And these are some numbers, all right? We don't have numbers. There was a few years where we didn't have any numbers, and I've been trying to track them down. We had a change in our nurses that were in the clinic there. We don't have those numbers. We were trying hard to find them, but this is our numbers. So this is Edmonton. This is Calgary. So way back in 2013, Edmonton sent 2 patients to Toronto for a pulmonary thromboendarterectomy. Calgary sent 8. 2014, we sent none. Calgary sent 7, et cetera, et cetera. You can see Calgary was really ramping up down there. So they were identifying more and more cases and sending more and more cases to Toronto for PTE back in 2017, 2018. I think that's probably a lot of the leadership to Doug Helmerson and really sort of identifying these patients. There's a void in our data here. We're gonna have to go back and dig through literary paper charts to find this data. We just haven't had time to do that. But last year, now that we started collecting data again, a lot of the kudos to go to Kimberly Lindroth and the rest of the pulmonary hypertension team for keeping track of this. Last year, we referred 20 patients from Edmonton to Toronto for PTE. Still not the 150 that we should be finding in the province. And I think about 10 of those, about 50% of those, so we're sending more for assessment. Some of them now are getting balloon pulmonary angioplasty, but it was actually about 10 patients from the Edmonton program ended up getting a pulmonary thromboendarterectomy in Toronto. So the numbers are increasing, but that still means there's a huge number of patients out there that are probably struggling with shortness of breath and other symptoms and quality of life issues that we're just not identifying. So hopefully we can start to increase the understanding and awareness of the disease, increase referral, and hopefully help more Albertans. That's it for me.
Thank you, Dr. Stephen. That was wonderful. 2 very quick comments, just because we have both surgical and medical residents. So they say that learning has 3 phases: studying on books, practicing with patients every day, that's a real school of medicine, and 3, mastering, becoming very good in something and actually being able then to innovate. And to do all those things, you need persistence and passion. And you have 2 wonderful examples of this here, of the beauty of working in places like this one. So get inspired. And 2, yes, this is something very not unique, but rare seen. And I don't think there are more than 50 centers around the world probably performing this. And, you know, we are really leveraging on the success of the transplant and surgical programs. I have no doubt, guys, that the preparatory work you have done, you will be one of the best centers in the world with this. So really kudos, I think Dr. Dawson and everyone will agree with me. Let's say questions from the audience. Please also have some question in the Q&A if you like, otherwise I will break the ice. So Jason, you showed very clearly that this is disease also leading to remodeling, right? So I assume that selection of the patients is really key. I mean, studying the patients very carefully and selecting the patients very carefully for the intervention would be the key, actually, the most important part of them leading to the success of the outcome. I remember patients that failed very badly for this. So what is your take and what are you really doing to target the best patients to get to progression people?
That's a great question. I mean, I think the key answer is that it's a multidisciplinary discussion, you know, between that balances the imaging, the hemodynamics, and then the surgical approach. One thing that we know, and some of the data from San Diego shows, and Dr. Meyer alluded to this, but the higher the pulmonary vascular resistance, and also sometimes we look at things like the pulse pressure in the pulmonary artery. When the pulse pressure is narrow, that often reflects a lot of downstream distal disease, some centers do operate on those patients, but you need to be prepared for RV failure post-op, because you may get out the proximal disease, but they've got a lot of distal disease, so they still have high pressures. The RV fails post-op, and they can end up on ECMO. They can still do okay once you get them through that. You add medical therapies post-op. In many centers around the world now, they're doing multimodal interventions. So they may actually, there's a clinical trial that shows that if you start with medical therapy and then do angioplasty, you have better outcomes. So a lot of patients will pre-treat them, then do angioplasty, and then take out the operable stuff. Because if you lower the PVR and the pressure preoperatively, you have less of that risk of post-operative right heart failure. And so then those are the patients that fail and sometimes either die or end up with sort of urgent lung transplantation listing because they have so much of that microvasculopathy. So really the answer is it's a very careful and detailed clinical assessment and a multidisciplinary discussion that balances what we're seeing and surgical risk.
In patient selection is key, and a great example of it is actually, and I have to give credit to Dr. Modry. He actually did 4 of these cases about a decade ago. And the first 2 cases went perfect. They had the perfect anatomy, kind of level 1 level. I've reviewed these cases in detail. Level 1, level 2 disease, minimal comorbid health conditions. And they went well. The hemodynamics were great afterwards, and their length of stay was right within the range that we'd expect. Case number 3 was a patient that had, her anatomy was great. She had beautiful disease, tons of comorbid health conditions. So very high risk. So not unexpectedly, she did spend months in the hospital recovering. She did eventually go home and actually did quite well, but did have a very prolonged course, not because of the surgery, not because of her surgical anatomy, but due to her comorbid health conditions. And again, Jason and I are working real hard to avoid that kind of patient population at this point, and the rest of the team. And then there was a 4th case, and this is where patient selection is so key. It was actually a patient that came in. It was a pulmonary embolus, and they took it to the OR, and they realized it wasn't a pulmonary embolus. There was thickening of the arteries, but she actually also had she was I think 60 or 61, had a VSD as well. So they did an endarterectomy, but in the end, it was an Eisenmenger. So it was kind of bad. It was intraoperative decision making. Thought maybe this was CTEPH. Didn't go well. In the end, it turned out that her hypertension was actually due to her lifelong VSD that had never been detected, and she actually had Eisenmenger. She did very poorly. She ended up on ECMO. She actually did get emergently lung transplanted, but eventually died. So that is a case. So maybe that's the case you might remember. Everybody remembers that case when we were starting this program a few years ago. Where they're like, "Oh, those patients all did poor," and I actually said, "No, it was just one case." So it is. That's why I like to bring that up, because it is patient selection is absolutely key. And that's why we don't do emergent cases. We spend a ton, it takes months to work these cases out. It's like the lung transplant program. We spend months doing all these assessments and imaging and more imaging if we have doubts, and more meetings about them and discuss them. So no, it's patient selection is key.
I just wanted to address one of the online comments or questions, which is how do you refer these suspected patients? So I would send them to the pulmonary hypertension clinic first, which is available in Connect Care, or directly to Dr. Ria Verghese, who's the medical lead for this program. And I just wanted to give her a shout out for all of the work she's done to really organize this, and all of the administrative work to get these patients moving, get all of the tests organized in a timely manner. So you can refer directly to her, to myself, or to the PH clinic on Connect Care. And then one comment here was just about the need to collaborate with the thrombosis group, and I strongly agree with that. And I would say we've developed sort of informal good relationships with the Royal Alex Thrombosis Clinic. We actually get a lot of referrals from them. They're actively looking for this condition, and as they follow patients up. So I would also encourage, GIM or hematologists at this site to look at this very closely, and to send patients to us if you have any concerns. Another comment from Ria online actually is that, for referral triage, if you think you have these patients, is to get an echo and a VQ with the referral. And if the VQ is positive while you're waiting, if you could order a CT pulmonary angiogram. We often do this as we're triaging the referral, but if it's already in the queue and cooking, it makes things faster for the patient to get evaluated. Because again, some of the VQs actually aren't CTEPH if they're positive. So to have a CT pulmonary angiogram to confirm that by the time we see them in clinic is very helpful. Go ahead.
Not to mention there's many underlying reasons why this happened with the antibiotic, malignancy, etc. When you look at the larger centers, have they stratified whether the underlying cause impacts their outcomes?
Yes, I think that there's some series on antiphospholipid antibody in particular. They do a bit worse, and also the splenectomy patients, because they tend to have more distal disease. So you get into that same issue with, they may have some surgical disease, but there's a lot of stuff that isn't accessible to surgery, and they struggle with either incomplete responses or postoperative heart failure. And then the anticoagulation strategies for the antiphospholipid syndrome can be problematic. We also, a couple of years ago, had a patient with HIT that we had to send to Toronto, and so that was a bit complicated as well to bridge them, with non-heparin anticoagulation in the OR, but it can be done, and there's published literature on how to do that.
Dr. Forgy here.
Thanks, thanks to both of you. Excellent talk. Really enjoyed it. My question is for Dr. Meyer. I'm really interested in the timeline, the obstacles in developing a new program from scratch. So, are you able to summarize maybe like a couple of points what the major obstacles were and why maybe the 15-year timeline as opposed to a 5-year timeline?
I'll just repeat the question for those online so
Yeah.
they can hear. So Dr. Forgy in the audience asked about the obstacles in establishing a new program, and sort of if Dr. Meyer could talk about the timeline on establishing something.
So the first thing is just finding the time to do it, and you get into practice and suddenly this is great for you. If anybody that's going into practice in the next couple of years, you will suddenly get inundated with a whole bunch of new responsibilities. And you have to kind of triage where you want to put your time. And I focused my area on a certain number of things, and lung transplant and heart transplant and a few other programs I was involved with. So you've only got so much time in the day, and you've still got a family at home that enjoys spending time with you as well. So there's only so much time. And then the next key component is having the right group of people and getting that inertia. So it was actually, you've got to give a lot of credit to Dale Lean, actually, who I think actually really kind of gave Giant and I kind of a little bit of a boot in about 2018, or sort of a nudge, I should say, it's time to really get on with this. So, so you shuffle your schedule around, you shuffle your priorities around. Some priorities you have to hand over to other people, and then you start building. Then you build that inertia, and it takes a lot of inertia, and then you get the right people. We actually went down to San Diego in 2019 and did training. Giant and I and Joel Berube, and it was the three of us. It was surgical training at that time. And but then we came back. It takes a little while to get everything organized, and then COVID hit. So that's the next big thing. So COVID hit, ORs are shut down. There's no room for doing anything new. So for a year or two, there was COVID. We weren't trying anything new. We were just kind of doing the regular open hearts. But by then you kind of lost your inertia, right? So but we got Jason and Rhea came back, and Dale came back, and we're like, okay, let's regroup and get the momentum going. And it takes a lot of momentum to get this off the ground, getting the right people together. That's a pretty impressive list of people we've got there, and everybody's really keen and involved. But it takes a little while to get that coordinated. You're writing protocols. So it just takes time, prioritizing. But you just keep persisting, and you've got these things in your list that you want to do, and you eventually get to them.
I'm sorry we are up to time. Actually, 5 minutes is all been expected, but please feel free again to come here and chat with Dr. Meyer and Dr. Weatherall. Again, this was a great round. Thank you so much.
Thank you.